Good morning from New York and anywhere you may be around the globe. Have a good day. This is the very seminal day, the beginning of the Structural Heart Life Cases. At this website, the structuralheartlifecases.org. And welcome, Mount Sinai Medical Center Cardiac Catheterization Laboratory. The first case will be of a transcatheter aortic valve replacement. But before we go to the cath lab, let me just go through some logistics. First of all, you can communicate throughout the case with myself and the operators. I will pass on any questions you may have if you send it via email at info@structuralheartlifecases.org. You may be very familiar with our programs that we have coronary live cases as well as peripheral and endovascular live cases, and we also hold several conferences at Mount Sinai Medical Center throughout the year. Many thanks for those of you who came by in person last week for the top 10 advances in clinical cardiology conference, which we held last Friday here at the medical center. Again, structural heart disease is becoming an entity of its own in interventional cardiology, and transcatheter aortic valve replacement is here to stay. Very many cases at Mount Sinai and elsewhere. Maybe you're starting your own programs. You're interested on how the setup of complex cases may be and how we integrate imaging. For myself, again, George Dangas, I'd like to welcome you to this program. And before further delay, and I want to give you a preview that this program is going to be regular. The second one is going to be on December 9th. Every other month, we're going to be holding this on a Tuesday morning, exactly the same time. And let's go now to the cath lab and welcome Dr. Sharma, Dr. Kinney, and other operators there.
All right, George, thank you very much for the great start. And actually, if we can get up my team here, Dr. Kinney on the left side and Jason Kovacic on the right. You guys want to make a good. And fellow Faisal and Dr. Partho Gupta is our echocardiographer, and Dr. Stone and Dr. Basil, anesthetist and surgeon, as usual, missing in action. But will be joined very shortly.
He will join for the critical part of the operation, that's for sure.
That is true. I mean, if you see, I don't know whether you can have a bird's eye view of this room. There are, like, any time you do a tower, there are probably 15 people in the room, and of course that's why everybody talks about how this procedure is not cost effective. But I think this is what requires just kind of a surgical setup being done in the cath lab. And we know majority of the TAVR procedures, whether United States or outside, even the French registry showed 83% are done in the cath lab. Very rarely you need a hybrid OR, which is more expensive. And so yes, in a more complex cases, like when you do a cut down, and so definitely the OR is the helpful hybrid OR, but otherwise they're routinely being done in the cath lab. And as you mentioned that, yes, we have been conducting our coronary live cases for 5+ years and endovascular peripheral cases for about 2.5+ years. And now is the next frontier, and to me is the most exciting, and I'm sure for all as an interventionalist, the most exciting arena is the percutaneous valve replacement, or TAVR or TAVI, which we say. And we felt that it will be a great start to show a case of CoreValve TAVR and to start this structural heart symposium. And with that note, I really thank our viewership, and of course this decision was just made in last few weeks. We have sent our appropriate communication, e-blast and so. But most important point is that we need to ask people questions, what we are doing, why we are doing, so we have an interaction. That will be great. Anu, you any point your side?
No. Let's start with the case presentation.
Yeah. So let's start with the case.
See how things go.
Good. Now today's our heart live case supported by Medtronic, the BARD, Assist Medical, and Terumo Medical Corporation. Next slide. And these are our conflict of interest. Actually none for the today's case. Next. Now this is a 77-year-old, little unusual, and we'll say because most of our these patients TAVR are 80-90+ years old. This patient actually presented with exertional dyspnea and chest pain, had prior PCI but clearly was admitted and has multiple medical history as shown here, but patent stents now, non-obstructive CAD. But one of the important issue in this patient has a breast CA, had a right mastectomy, and in the almost 20 plus years ago, but then found to have chest wall and liver mets just about 6-8 months ago. And she was started on chemotherapy and apparently is responding by the tumor shrinkage size on chemo. So therefore, our oncologist colleague has given us minimum 3 to 5 years of life expectancy, even more. So clearly we know that if your life expectancy is less than 1 year, there is no reason for TAVR. Maybe just do a balloon valvuloplasty. But if the reasonable life expectancy, which in my opinion should be more than 2 years, she qualifies to become a TAVR, not necessarily from the risk point of view, but from the extreme, the inoperable point of view. And this I will talk about various trial results and so. Patient of course has aortic stenosis, which will show you the echo point of view. And also important is that every case, particularly more so for CoreValve compared to our other sapien, that is that we need to pay extra attention to the EKG because of the QRS width, PR interval, and so because of inherent incidence of need for permanent pacemaker. And we know that many times permanent pacemaker, when you leave it for 2-3 days, it actually increases the patient's hospitalization. And many of the cases when we know it's a high risk for pacemaker, and that is our electrophysiology colleagues tells us, then we are implanting the pacemaker at the same time after the TAVR implantation. This patient has very right heart cath with a mild pulmonary hypertension and the wedge pressure and severe aortic stenosis. Next. So these are individual we'll talk about, and the CT angio and STS risk mortality, as I mentioned, is 4.15, and which makes it low risk or intermediate risk, I would say, because intermediate risk of the STS mortality is between 4 and 10, but recently now it has been decreased to 3 to 10. Actually in Europe they call it 3 to 8 as an intermediate. We call 4 to 10 because the trial designs, but now it has gone down to 3 to 10 in United States also. So it is a intermediate risk. But this patient is extreme risk for surgical AVR due to metastatic cancer with the projected life expectancy, as I mentioned. So patient is planned for CoreValve TAVR via percutaneous left femoral access and the conscious sedation. And that is the important point in recovery of this patient, that you do under conscious sedation, so that no intubation, rapid recovery, and patients goes to the coronary care unit for observation. If they need a pacemaker, temporary pacemaker, we leave in situ for 2 to 3 days, and after that, if not, within 24 hours can be taken out of the CCU. Also, what we learn more and more now, that we used to be very aggressive in various invasive monitoring, whether it's the arterial sheath or swan, and so many of these patients who have good LV function like this, in the end of the case, except the temporary pacemaker from the neckline, the patient should come out of the cath lab without any swan and without any A line. Next. Now this is the echo. Maybe Partho can just comment on this.
Yes.
Yeah.
So the echocardiogram is showing severe aortic stenosis. What you see right now is the continuous wave Doppler, where the gradients are suggestive of severe aortic stenosis, mean gradient of 48 millimeters mercury. You can also see it in live on the screen. If you can show the screen on the echo on the screen, is there a possibility to show the echo on the screen?
Show the echo screen, please.
Yeah. Yes. So this is a live. So you can see here the patient has this is a transthoracic echo. So the entire procedure is going to be done under transthoracic, not TEE. The patient has a good apical window for guiding. This is a 5-chamber view. You can see the calcified aortic valve. The LV function is well preserved. And if I show you through the screen, this is the current aortic valve gradient, 45 mean against severe aortic stenosis. One important question that comes up is how much is the amount of AI? So the AI is trivial to mild, and more importantly, since this patient is really young, it's important to make sure that bicuspid. So the patient got 3 leaflets. So it's a tricuspid aortic valve stenosis, perhaps accelerated because of her cancer and other comorbidities. So overall, the anatomical details are well seen here. And the only point that I have pointed out to the interventionalist team, that there is a little bit of sigmoid septum. This is not a hypertrophic cardiomyopathy. This is just a a little bit of bulge, but there's a lot of space from the aortic annulus to about 8 to 10 millimeters for the valve to land there. So this would be not prohibitive. There's no gradients of valvular gradient. So this is a patient with severe aortic stenosis, tri-leaf LV ejection fraction.
Great. Next slide now. We can go to the slide. And clearly these cases require extensive workup before they get here. And of course the selection of the valve size, the access and so, and this is the simple formula which based on the mean aortic annulus, we decide which valve to be used, in this case being a 24.7, which is suitable for 29 millimeter valve. Next.
Well, let's spend a little time there. Let's go back to that slide. Let's spend a little time there for the audience to understand exactly what the possibilities are here. And I don't know if maybe Jason, who does the analysis of this CT, maybe you want to spend just a little time to tell us what are the different possibilities here. We understand that this fits well for this type of CoreValve, but what other options might be here, because we see the perimeter, we see the area, we see the minimum and maximum diameter. How do all these interplay into the decision?
Sure, thanks, George. In the early days of TAVR, the valves were just sized on one plane diameter, and as I think this annulus highlights very nicely, most annuluses are not truly circular, they're elliptical, and you can see here this is certainly elliptical with diameters in the short axis of 22.5 millimeters, in the long axis of 26.9 millimeters, gives us a mean of 24.7. So for a few years we were sizing based on the mean diameter, but we've now really moved away from that even, and with the CoreValve we're placing in today, we size off the perimeter. So the perimeter in this case is 78 millimeters. For the other balloon expandable valves, we tend to size off the area, which is 4.7. We don't really rely on that measurement today, but I just think we included it for your interest. But you can see they're certainly elliptical, and this gives us time to consider if we have to, when we pre-dilate and post-dilate, what our selection of balloon aortic valvuloplasty balloons will be. So based on the mean of 24.7, we'd probably choose, knowing these diameters, to go with a 25 millimeter post-dilation balloon as a reasonable starting point if we needed to post-dilate for paravalvular leak. You can also see there's a little speck of calcium there on the right side in the middle of the annulus. As we moved up and down the annulus, we haven't shown you all the images. There is certainly some annular calcification we need to be aware of, because that can obviously cause trouble if we very aggressively post-dilate, and we can cause trouble with annular rupture. So a lot of information here, as you said.
And I think that's important, that if we need to post-dilate, we try to consider the minimum of the diameter. No, we don't go to the maximum. We go like, don't try to exceed the mean, of course, but maybe a little more. Really don't want to go beyond. So it means sometimes it could be 18 versus 27. So we'll try to go with a 22 millimeter. If it is 21 and 27, we may go to 23, 24. So key is that to avoid the annulus rupture, you do consider the minimum of that annulus diameter.
And we can consider some of those when the time comes. Also, that's a very interesting discussion. How do we counterbalance the optimum apposition and elimination of paravalvular leak with the possibility for annular rupture, and how do you keep that balance? And obviously, you know, if we get an annular rupture, then there is no point in professing about the long-term result because you have an acute complication. Anyhow, and
actually, Dr. Ani Anwani had just joined us. Maybe clearly that will be all set with the, now we make our complete team. Okay, let's go to the next slide now. Next slide, yeah, we'll continue.
So just moving through, we're taking you through all the measurements we need to put in a Medtronic CoreValve. The ascending aortic diameter there you can see is 31 millimeters. Although we don't need this for the sizing, the annular angle is about 44 degrees. So that's a reasonable angle, nothing too extreme there. When that angle is more than 70 degrees, the annular plane is lying very horizontal, and that brings its own set of challenges. But today's angles are fairly standard. Next slide. So other measurements we need to consider, the sinus of valsalva diameter here is about 30 millimeters on average, and the sinotubular junction height above the annular plane is about 21 millimeters in average. So next slide. So here you can see the sizing table for the CoreValve, and you can see here we've got in the red box the 29mm valve, and our patients' numbers down there in yellow at the bottom of this box. And you can see clearly by all parameters this patient fits neatly into the middle of the sweet spot for a 29mm valve size. So on aortic annulus diameter, the ascending aorta diameter is less than 43, which it needs to be. The sinus of Valsalva diameter needs to be more than 29, which it is. The height of the sinotubular junction more than 16, which it is. And the perimeter, as I said, which is probably the most important measurement for sizing of these core valves, 78mm, right in the middle of a 29 valve. So no question here, it's a 29 valve today.
And that is also important point. Remember, there is always an overlap of few millimeter in various valves. 23 could be 26 or 29. The 31 valve could be 27, 26mm, and so key is that we learned over the years that it's better to go to the bigger valve, and if need to be, just don't post dilate, but go to the bigger valve rather than the smaller. So that if you have a 26 or 27mm, will you go with a 31mm valve? And I think that's a very important point, because the prosthetic regurgitation residual does have something to do in the long term, although not has not shown clearly with a core valve. But I think idea is just use a bigger valve in those overlapping range, as long as other things allow. Your perimeter, your angulation, everything is good. So you try to go to the bigger valve. Next.
So just some other considerations, not related to the sizing, but to the deployment. Certainly our left main height today is 14mm above the annular plane. When it's less than about 12mm, we start to get concerned that we need to be worried about left main occlusion, but 14mm, it's not an extremely high left main, but it's comfortable enough that we don't need to be particularly concerned about that today. Next slide. So to the access. So there you can see the 3D. These iliofemoral vessels are fairly straight, not tortuous. There's a little bit of spotty calcification, but nothing too concerning. And 7 to 8mm all the way up on both sides. For this Medtronic CoreValve, we need a little bit over 6mm, depending on tortuosity and calcification, to safely get the sheath in and out. So 7 to 8 gives us plenty of room today. Next slide. These are the kind of small attention to details that can really make or break a case. When we look through very carefully the whole iliofemoral system, what we actually found in the right common femoral is a dissection. This patient, as you know, has had multiple PCIs, has been accessed through these femoral arteries many times. Other closure devices have been deployed here. So this right common femoral was dissected. So really clearly our only option for today was left femoral access. And you can see there the left femoral looks reasonably clean, just a tiny bit of calcification there, and it's a nice diameter. Next slide.
And this puts it together, the summary of this case, that patient is, by every means, I would say for a start, could be the best potential case which could be possible. And of course, going with our core valve, as you mentioned, in 29mm with the left femoral approach under conscious sedation. Now the valve itself, I talked about, and I'll talk about the data and of course the implantation. The valve itself, there is a lot of kind of complexity, but simple complexities which we need to understand. Next, in terms of the valve issues and so. Next.
Good.
No.
Next slide.
What happened to next? Yeah. And you want to talk about this individual valve deployment points? Yeah.
Check.
This is the one.
Yeah, this shows how the valve is sitting and the relations it has with the different structures around it. The valve is essentially stabilized in the annular plane. There is a skirt that has a 12mm length or height, however you want to call it, and around that this is a non-permeable skirt, and therefore there is no communication within the struts and the circulation in that area at the very bottom of the valve. And above that,
yep. Now I think that's a very important point. Important point is the valve leaflets are above the lower part. Each diamond is about 8mm. So valve leaflet sits above the aortic annulus. If we go to the lowest cusp of the aortic leaflet, and the annulus, the valve itself in this cage of the core valve is about 12mm above. the total height is between 50 to 55 millimeter. But clearly the height is one, which is not much important. We know that it has to be depth-wise, about 4 millimeter and so below the annulus. But the key is that the valve leaflets are about 12 millimeter above the lowest area, and so that when they are opening, so we need to know where exactly it is in the process, and gives you enough height for the particularly for the left main, and that is the key, that for the left main it gives the enough height and so. Okay, now with that, now we want to take particularly about this case now, while we're miking up. Yep. Tell about the access now, how we case being done now.
Yeah, let's go to the angio scene so we can see how the access was prepared. That will be very important step now. We saw the CT angiogram, not much calcium, not a lot of tortuosity. Yeah. And we see over here there is a selective angiography with a macropuncture microcatheter. Is that right, Jason?
Yeah, so anatomically we just went off the femoral head landmarks with the microcatheter. You can see here on this shot we're nice and anterior and square on the front of the vessel, and a very nice place to puncture right in the middle of the common femoral. So the next step is then we get our root angulation shot.
Yep. So the key is you want to go to the lowest, the non-coronary cusp, which is the lowest, and that's where you do, because the valve, as I mentioned, that it has to be about 4 millimeter below. Although some bigger size you can say 0 depth and all those, but key is overall with the CoreValve that you start about 4 millimeter. That's what you are aiming at actually. And of course individual steps, like in the particularly compared to the previous picture, this is the right picture, that now you are in the non-coronary cusp, and that is your plane. So that's the imaginary line you need to draw. There are various programs which have come up with this, but we found them not that useful. I'm sure some people will be useful, those programs, but I think once you have that mental setup, that is what you need in these cases.
In fact, a small trick we learned here is to take a tiny shot deliberately in the right coronary cusp. You can see we opacify nicely everything here, just a small amount of dye. When we're happy we've got everything lined up in both planes. You can see the 3 base points of the cusp, and we're in a nice line. Then we put it into the non-coronary cusp and take a full shot here. So moving forward to the access, here we are inserting the sheath nice and gently, and we're watching to see there's no calcium moving, no problems. The sheath went very easily. This is a expandable solo path sheath, so the sheath actually goes in at a diameter of about 13 or 14, and then we actually inflate the sheath. You can see here this is the sheath being inflated, so the sheath comes with a very long balloon that goes right up the center and expands here. We put that up to 20 atmospheres for 1 minute, then we deflate the balloon and remove the balloon, and we're ready to go with our sheath.
Now let me make clear that right after that, in between this shot we saw before with a microcatheter and this advancement of the sheath, Jason deployed a couple of Perclose devices, ProGlide devices, 90 degrees to each other, and then took them out, left the stitches there without tying the knots obviously, and then inserted the sheaths over the wire. And we use a stiff wire to do the sheath insertion into the aorta. These stitches are going to be left in place, and they will be tied in the end of the case. I'm sure we're going to go there. We're going to touch that at that point of the case. So right now we have a expanded solopath sheath, which is 18 French from the left femoral artery, common femoral artery. We have a pigtail, which is a 5 French sheath via the right common femoral artery. We have a right side vein that has a pacemaker and through a long sheath, and we have an IJ access for a swan. And this is a setup for the case.
Good. Anu, you take over now while we are getting a mic for Dr. Ani. Change it. So now our plan is, now we have taken the pressure on both the femoral and the aortic. Did we check it?
We just, we have to cross the aortic valve. We are going to use an AR2 since the annulus size is small, and the wire that is being used is a straight Terumo wire. So the anticoagulation is heparin. Heparin has been given ACT about 350.
And Josh, talk about using bivalvulotin in these TAVR cases. I know you are involved in that.
That's a good point. The anticoagulation we did not really touch much as of now. In these percutaneous cases, we load the patients with aspirin and clopidogrel, and during the procedure we use heparin with an intention to reverse the anticoagulation in the end. There is an ongoing randomized trial in Europe and Canada already going on for the last 2 years with randomizing this strategy with bavaclurudin, bolus and a short infusion, obviously without reversal during the case, and this is projected to have a total of 800 patients, and thus far almost 500 patients have been enrolled and randomized actually.
And when is the trial coming to US?
Trial is supposed to come to US by the end of the year, beginning of the next year.
Okay. Beautiful. So as you saw that it's a combination of AR2 with the stiff shaft straight terumo. Many times based on the aortic root size, you go to the either AR1 or even the AL1. Here is like a medium size. So that the question is many times if it doesn't point correctly, you may change it to a to AL1. But I think it's you just need a little manipulation and point that while we're trying to cross here.
Maybe you can take that a little bit more LAO to allow you to see better, open up
okay,
the...
We go a little more,
open up
slightly more,
yeah.
And then maybe now Ani is actually fully mic'd, and maybe we'll ask clearly the role of that how they feel with this percutaneous approach over the years. All have been done surgically. And how these cases are being done, many of them in a very quick fashion compared to taking few hours of the OR time. Ani?
Well, I think it's more a matter of choosing the right procedure for the right patient. And we see more as a team-based approach. So patients come with aortic stenosis and we decide the best approach to treating them. It might be surgery, it might be a catheter valve. Whatever the procedure is, we provide it as a team. And I think that's the key. There are some patients for which the catheter is the best procedure, some patients for which surgery is the best procedure. And there are some patients who are in the middle, and for those, it's down to the choice of the patient what we do, and we offer them all the options.
And I think that's a very important point. Remember, everybody felt that by once the TAVR starts, and particularly clinically approved, it will erode the surgical volume. And as far as the latest data of 2013, it has not affected the surgical volume. Actually, surgical volume has grown by SCVR by 1 or 2%. The growth of 8 or 10% has occurred because of the TAVR. These cases probably were not getting anything. Of the 250,000 aortic stenosis, the SCVR is done in about 45,000 patients only. So therefore, clearly there is a lot of room. So basically the TAVR is additive. Now, Germany, as you know, is the biggest center in the world using the TAVR to even low risk, younger age and group. There actually now, it's about 50-50. Overall in the country, 50% are getting the TAVR and 50% getting a SAVR. There also, the SAVR number has not decreased, maybe just a slight decrease, but majority of the growth has occurred the cases which were not being treated before by definite means. So there's always sometimes a difficulty. This is a simple thing of the first step, even after doing 1,000 cases, but now it's
okay. Let's go to the RAO now. We'll position that into the ventricle.
Now, after this has been done, and I think this is the most important point, is that using the wire to exchange your devices and need enough power. So what we basically use is the stiff shaft and make it a curve. Now if you can show this curve here, very important, because some of the cases of perforation occurs because the curve is not correct.
This is a very important detail to make this several curves, because obviously the wire will be straightened while it goes into the catheter, and unless you make quite a few curves, you're not going to be able to maintain at least one of them. inside the wire. I mean, in the meantime, the catheter, I think, may have moved a little bit outside, so what do
So
Came
we'll
out.
go back again. Yeah.
Go back. Yeah.
Go back to LAO,
Yeah.
please.
Yeah.
That's why it's, it's interesting that although the LAO is easier to cross, it kind of foreshortens the LV.
Yes.
And that's why we find it interesting once a wire crosses to switch a little bit to the RAO in order to have a full understanding of how deep you really are in the LV and help maintain that position and reach the apex of the heart more securely and geographically. Of course, now we have the echo guidance as well, and I know Partho is Dr. Sengupta is very careful about advising us when the wire goes in and out of the mitral apparatus and all that, and if it's in the true apex or the mid cavity or towards the lateral wall and all that. We're going to hear a few of those comments as soon as we ascertain wire position and cath position once again in the LV.
Yeah, while the wire is being done, can we just finish our didactic discussion of the slides?
Yeah, that would be
I have about
good.
like 10-15 slides, but we should continue. Maybe the angiogram on one side. Yeah, good. So go back to the previous slide. Yes. The
Show in the
goal
small-
today is
in the small
Yeah.
small screen. Show the angiogram. Go
angiogram.
ahead.
Yeah, not necessarily the yeah, very good. So basically, we're just going to talk quickly about the latest data on the pivotal CoreValve trial, which was done for extreme risk patient, which means inoperable, and the high risk, with the STS mortality of 10 to 15%. Some of them were incremental. Next. And these are the two trial design. Extreme risk, as you can see here, and there were about both iliofemoral as well as the non-iliofemoral, and of course the high risk, about 800 patients. Next. One presented last year in TCT, other one presented by Dr. Adams in ACC this year. Next. And I think these are the trial study design. Next. We can just breeze through. 40 plus center, 42 actually, then later on became. Next. And basically the patient with the severe aortic stenosis symptomatic. Now we should continue the small picture. I think we should continue. Yeah, fluoro.
we
Keep
stay in
next.
the small picture.
Yeah, which is fine. Yeah, next. The usual exclusion criteria of those patients who should not get the valve were excluded. Next. And basically found that overall the mortality was 24%. And actually better will be that side picture if we bring it to the bottom. Yeah, let's say bring it to the bottom. That's better. Yes. That 1 year mortality 24%. Remember, similar type of patients in the partner trial, cohort B was about 30%, but it's about the same range. In that, of course, a little difference in the patient, but more important is the major stroke was 4%. Next. And these are the various complications, the most important being the pacemaker, about 22 to 27% need for pacemaker. Next. And clearly the technique is very useful for the improving their heart failure symptoms.
Don't move it anymore.
Next.
Yeah.
You want to position
Again.
still.
Let's
Next,
take a
this is
slide
paravalvular regurgitation. An important thing we learned compared to with the Edward Sapien data, that even mild paravalvular regurgitation was associated with a late mortality. That is not true for the core valve. Of course, in the severe basically means it's a failed TAVR. So in those cases they're different, but clearly it was not correlating, so very reassuring. Next. And of course the major pivotal trial of the extreme risk group. Next. Which again the idea was to compare the stroke and death. Next. These are the various individual baseline demographics. Next. With their comorbid conditions. Next. And actually very interesting, and I'll ask Ani to make a comment on that in the study they found that aortic valve area was better with the TAVR versus SEVR. It was like average was 1.9, while they got about 1.6 with the surgery. Knowing that, Ani, you were involved in many of these cases. You want to comment on this slide?
I think the issue with the surgical valve, because we leave a stent in the valve, we'll always have some compromise in the valve area. So the stentless surgical valves, as well as the catheter valves, generally have a better valve area than the surgical valves. But whether this is of any clinical significance is not proven. So the marginal benefit of the catheter valves on valve area has not been related with any clinical benefit.
Okay, great. Next. So we'll complete, and then actually this is a very interesting and exciting that your mortality was 14% versus 19%, about 5% absolute reduction, which makes the p-value of 0.04 for superiority, while the trial supposed to be, as you saw, that equal, but clearly favored the CoreValve transcatheter compared to the surgical valve replacement. Next. And another important is the major stroke. As you can see, the no longer higher. Remember in the partner trial data, it was double. 30 days was 3 to 6, and it became 6 to the 4 to 8 at 1 year. So clearly the double thing of the CVA has disappeared with the CoreValve. So numerically lower, definitely not higher. Next. And these are the total stroke. Next. And these are the individual endpoints of the vascular complications and life-threatening bleedings and so. Next. 30 days and 1 year. Next. Same, that both techniques improve the heart failure symptoms. Next. The difference was you leave more paravalvular regurgitation with the TAVR versus SAVR. Clearly, as Ani pointed out, that you really show it, and it's a really nice fit, and you do leave some regurgitation, paravalvular regurgitation. But at the same time, we understood that it's not only the severe one you need to worry about. Mild moderate has a similar mortality in the extreme risk group. Next. And of course, now we are learning that in the newer studies, newer valve, maybe the smaller design will have a lower CVA rate, as shown in even with the SAPIEN XT data. Next. So go back to now. We are ready for this case. Go to.
Yeah, very good. Let's see. Can you maximize the angiogram, please?
Yep, now we can maximize.
Exactly how the wire has been.
So I think important point was the wire curve, which was shown how you make the wire curve. So we crossed the LV with the AR catheter. I mean, AR2 was not helping, so we changed to AL1. We got the catheter in, and what happened also, I think first time when we went in, as Partho already pointed out, that we were through the papillary muscle. It was deep-seated, and we could not pull back. So took the catheter out, and if you show the next angio, you see that? Back.
Yep.
Back. Yeah. So now we are actually in the apex. We are free of the papillary muscle, which is a very important point, which the echocardiographer will tell us. If for some reason we are that we are still embedded in the papillary muscle, is a submitral or anything, when they tell you, what you should do is place the wire like I show you the angiogram here right now. It has to have that O loop. If it does not, then you have to go back with the pigtail and reposition the wire. This is very important, so that this is one chance you have to reposition the wire. It has to be in the cavity, in the apex, so that your valve positioning will be better when you're truly positioning the valve.
You need to have a good support against the apex, otherwise the wire may move during the implantation and may either suck the valve in or a little bit out during the case. Anyhow,
this patient has actually same about 80 millimeter gradient, and now what we are doing is using the balloon valvuloplasty. It's a true balloon, which is a 6 multi-layer balloon, which is very effective in opening it, and rapid inflation and deflation is the key.
You're going to use the 22 millimeter balloon?
Yeah, 20. So in this case, we are going a little under because very tight gradient, and 20 millimeter, I would say, is our usual ZMAD is equivalent to like 22 millimeter. So it's a 20 millimeter true balloon.
Okay, pace?
Yeah, pull back a little bit. Good.
Okay, very good. So it is centered to the calcium, which is also the pigtail that helps a little bit. And now we'll pace at 180 and inflate the balloon. It came out very quickly and didn't move at all.
See, that's the advantage of this true balloon. Rapid inflation, rapid deflation, and you don't need to have a side attachment of the syringe, because that's once it gets the maximum diameter, you don't need to do anything further. It will not increase the size, but key is the effective area. What we have seen, that with a 20 millimeter balloon, you will get it compared to 22 and 23 millimeter of our
mild AR.
Mild AR. Okay.
Right. Very good. That's another safety measurement. It's immediately after we do the BAV, you see on the right side bottom of the screen, Partho already checking with the echo probe, and he sees a mild AI. That's a good safety. And what's the blood pressure and the heart rate, so we get an idea after this maneuver?
The 140 and over 80, so far good. And now our valve loading team, maybe you can just show the camera on this side. The valve loading team with our Ricardo as a CVT, that clearly we are ready. Basically the steps are that we do the valvuloplasty when our surgical colleague is in the room, because sometimes there's severe AI, you need to have the valve deployment is a problem. So that time when you're doing a valvuloplasty, your valve should be loaded and ready, and surgeons have to be in the room when we are doing the procedure.
And another key point is, you always have three people. The primary operator, who is going to be the one handling the valve. You have the surgeon, who is going to be releasing the valve, and the second operator, who is the third person, who is going to be handling the wire. But only one person will speak. But that's very important that this has to be decided, the team members and who is going to do what, and everybody has their responsibilities, and the primary person is the one making all the calls, whether it is the pacemaker, talking to anesthesia colleagues where you need medication. One person makes the call, and that's how the team works together. So I think right now we have three people on position, right, and the valve is positioned here.
Very well.
Just go forward.
Yep. The core valve facing up.
Yeah.
And this is the 29 millimeter valve loaded.
If the core valve faces up, then the raphe of the valve will
as long
not
as
be
you-
lined up in front of the coronary.
As long as you don't have a lot of resistance, you don't have to pan how the valve is going. So we know it's going smooth. Very nice.
Makes a curve
Across
around
the
the
arch.
arch, and you can see that it's going to cross.
Now we
into
have
the LV.
we have had the pigtail there all the time, but I think at this time, since the pigtail has moved, what you have to do is pull back all the way and repositioning of the pigtail.
Yep.
And this is, I think, another key point which I want to say is the imaging projection. So now you have the pigtail again in the non-coronary sinus. Some die.
Not yet.
With
Move
that.
the small picture to the top
Yeah.
left, please. Now we can see that the
now you
Jason
see
has
that.
moved
Yeah.
the camera to more caudal. We're caudal 20
Can
now.
you redo so we
And
show
in
how
order
the
for
oval
the-
looks like? Move it.
In order for the marker at the bottom of the valve, you can see now that's the original projection. The marker at the bottom of the valve is elliptical, but if we go caudal as he's going now, the elliptical
we are not-
becomes a straight line.
Good. Okay.
Okay, so the important thing is how you're going to get the imaging projection. So you have the pigtail in the non-coronary, right? And I'm going to just take a cine and see. You see the marker band? It looks oval, right? So you
Right.
got to move the position so it becomes a line. By doing that, what happens is you're just going to define your annular plane. Can you go a little bit more so it becomes one straight line?
Yep. That's it.
Very good.
Now it's one straight line. So now you know the pigtail is the at the annular line. Now we got to go 4 millimeter, about 4 millimeter below the annular line.
Okay.
So one diamond is 8, but right now if you see there, I think pigtail is right there, some die.
And we do a
Just
same
about
thing like
4.
jiggle it, when you stent. So any tension in the system
Stent.
is eliminated. So they just jiggle, because many times where the valve will settle, don't know how high. So we take away the tension from the system. That's the key. Okay, I think we are good.
Okay, first cine. Inject.
Yep.
Okay, so we are
Good.
Okay,
4 millimeter below the annular line.
That's
Everybody
another
okay?
feature that you see is that these maneuvers, although we take our time, also they are done at the hemodynamic condition of severe AI, because the valve is across the aortic annulus.
Okay.
And
We start releasing now.
that's why we also cannot take infinite time. So
And that's where Dr. Stone will going to take care, keeping the blood pressure, and that is the key. Same. That anesthetist colleague basically will keep during this time. This is the crucial time that keep the pressure up, because right now it's causing AI, and soon it is going to obstruct the valve
Okay, stop.
opening.
And Annie is releasing now, has
So
released
he
about
have probably
6
done
millimeter.
about 20 turns, and we
I
know.
think we may need to go a little in. Let's see.
Okay, inject.
No, it's okay.
I think
So
we're still
good.
looking
So
okay.
far good. Okay.
So far looking good, and he's going to start releasing. That
You're
means
gonna
he's still
flare now?
occluded. Yeah.
Flare.
I keep releasing. We're going to start flare.
Dr.
I'm just
Stone, we
holding
may
the
need a
valve
little
good.
push in the blood pressure. Okay.
And now the valve is flaring. And
This
now
is very important. It flares
we
and
have,
it's going to anchor
arrest
the
now.
left sinus. Okay, so you wait till that happens. Release a little more.
No, no, no. It will be
Okay.
occlusive soon. You have to
Okay.
take a picture.
Cine.
I think
I
it's
think
very
you're looking
good.
good.
It's below the left
Start
sinus.
pacing.
Pacing 120.
Okay, start
So
release.
we pace now. Let me clarify that we pace at 120, not
Yeah,
at 180.
120. Release.
This is aims to avoid any extra beats or something that might push the valve out at the time of
I'm
opening
holding
the
it
valve.
tight. Yeah, release.
And-
Stop pacing.
And now we're kind of
And
stopping
we are going to
here.
take another cine.
Let me clarify
Good.
now that the valve is fully functional,
Yep.
although it's
Release.
still contained at the top.
Release.
No, but
Release.
the question is, you're ready to release or you're still too far in?
No, no.
No, I think let's see this one. Now, right now pressure is good. We are okay. Let's review the last
Yeah,
one.
what Dr. Sharma says is very important.
yeah.
Right now the valve is functioning, we have good blood pressure,
Yep.
and we still have the capability to pull it back a little bit if we don't
Because
we don't
right
like
now,
it.
by my definition, it's a full diamond, so the 8 millimeter. And let's see the expert here.
No, it's about
Heather,
6
what do you
on the
think?
left side. Partho,
What do you
it's
think
good,
here?
right?
Yeah, it's good.
Or should we
Release.
just pull? Because right now it's still attached. So you can still pull with the advancing wire board. Then you take a help from
It's,
Partho. What do you
it's
think?
about
Partho?
6 on the left side. On the right side is just about 7.
Yeah,
Right.
so it's a little bit
On the-
obliquely
on the-
sitting.
yeah, on the right
So-
side seems to be around 10.
I
and
think
on
when
the
we
left
release,
side
it will
about
reposition itself.
6.
Release.
Would not be able to do.
No.
So it's an average of 8.
Yeah.
6 and 10 average of 8. And sometimes
All
it
right,
moves
let's
and
release.
realigns
Release.
when we release it.
Hold the wire.
Yeah. Yep. Okay.
I will
We are
release it.
releasing then.
And we always release with a little
So when you're
forward push
releasing,
of
I'm
the
just
catheter.
going a little forward.
You're still attached in one
Yeah.
of them. And you can see still attached the catheter, so we have to turn and push
Yeah,
a little
it released.
bit.
It
and now
released. Careful.
it released.
Come out.
And now it's
And
coming
then you
out.
pull the wire, bring the nose cone in the center, and then you bring it in the aorta. And now he.
Good.
No.
I think it's ready, not exactly. You twist it a little bit so they get married very in an exact way and then take it out over the wire.
Somehow it is not
Not together
fully.
yet.
But also make sure we don't lose the wire at this point in time.
The thing is this. No. 1 second.
The
1 second.
opposite torque in order to marry them a little bit.
Yeah. Good. Okay. Now hemodynamics are good.
So we'd like to see the echo on the small screen if we can. We're no point to see the catheter changes, so we can have the echo screen there.
Yes.
We'll see
So
what Partho sees, and we can make it a little bit better if we can, a bit bigger if we can. That'll be useful.
yes. So what you see is that the patient currently has a paravalvular regurgitation, and there's also a central regurgitation, but there's a sizable jet paravalvular. I would call as at least moderate.
Is a valvular regurgitation from the left side or from the right?
Ready?
The valvular.
From which cusp is it?
No, this is a transthoracic guidance. So right now I'm an apical approach, and it's difficult to say, but there's a paravalvular leakage which is looking sizable, moderate, at least moderate.
Okay.
Let's
We'll
go
confirm
Vinay.
it with
Let's put it to-
angiogram.
Aerogram.
Far up above.
No.
The angiogram is a little ambiguous. We see that it's definitely some. The valve position is not high, it is not too low. So I don't think by position or malposition of the skirt is the reason for this paravalvular regurgitation, and perhaps was a little calcium that Jason pointed out in the CAT scan before.
Yeah. We need to
Still
increase the
we-
pressure. Pressure is on low side.
Still, we wait a little bit for the hemodynamics to normalize, and
Effusion.
perhaps we can take a
Effusion.
gradient
There is
across the
effusion.
valve, Dr. Sharma, and we can put
Now
a
there is
catheter
some
in there.
effusion has occurred. Let's do a pericardiocentesis quickly. Yeah, increase the blood pressure and give us a pericardiocentesis tray.
You want to remove the wire and put the catheter in the LV?
Okay. Hold the wire. Hold the wire.
Yeah.
Let's look at the echo on the small screen.
So the echo is showing development of a moderate size pericardial effusion.
Okay, we need to
bring us
pericardiocentesis straight quickly.
just a surgeon or PA.
What is the blood pressure there from Jason? You can summarize that while they're preparing.
You lie down.
The blood pressure is about 30 systolic.
Give epi. Let's go.
Do you have the surgical set?
Yeah. Now, if we need to intubate, now we can intubate. No, you don't need to go lie down. Go quickly.
If you scrub.
Go.
Since the valve procedure is essentially done, do you want to reverse to consider reversing the heparin?
Yes.
We can give protamine.
No, it's not filling. Tamponade.
Let's give 40 of protamine.
So
One of epi.
Fluoro.
Can you intubate?
development of
We have the pigtail in the LV. We can give any medication straight in the LV if we need be, but at the same time, anesthesia may consider reversing the heparin and intubating. But
And intubating, yes.
Dr. Sharma is attempting the pericardiocentesis, which looks like it must be in the right spot because it's really going well there, and there's a lot of effusion.
Should be there, no?
Well, we're definitely not post-dilating this valve.
Yeah.
We're going to need to do chest compression.
Please.
I think it goes a little bit too lateral. Maybe try to go a little bit more centrally. The effusion was more the effusion was more towards the anterior wall, maybe pacemaker related.
And I have to compress the chest. There's no.
We have to do epi or do a little.
Protamine here.
Not yet, I'm next ventilating the patient.
No, you're too far. No, way too far.
You need to give another.
yeah, you're there, almost there, almost there.
I was there.
Just tell me when I need to stop.
You don't need to
Wait,
stop.
wait.
You need to
No.
compress. You're giving more epi.
Okay. Keep on floor. Just 1 second. What do you think?
It goes too lateral.
We haven't.
Lateral, you have to go apically.
But we are not there?
Apically.
No, we are there. 1 second. Wire?
I don't know where you are.
Trust.
Okay, just 1 second.
You can inject some micro bubbles.
We are good, right?
Yeah, this looks. Can you pan a little bit more? Looks like the pericardium.
We didn't give bubble, nothing.
Yeah.
Bubble.
The wrong wire.
This looks like the pericardium. Let's pass the equipment.
1 second.
You
Fluoro?
want to give some bubble or no?
No. No fluoro?
Are you intubated?
We're past ventilating with oxygen. We eventually
Okay.
All
Can you
right.
prepare?
Well, this
No, no,
is
no, no. What
active
Lucas?
chest compression. You could hold the wire firmly so it goes. The aspect go in.
Bubble.
Never goes.
Keep it straight.
Bubble.
Now everything will be okay. It'll go. Keep it straight.
I have
Well, see where that wire goes.
Yeah.
Pan the chest a little bit.
Good. Okay. Anna. Okay. Aspirate quickly.
Arvind, the thing,
No, I want to see the bubble.
I saw that
No, but you have to
injected it.
Well, the last position of the wire was going a little bit too much north, but
Huh?
we can
It's
see
not
what
there?
it is.
Huh?
Yeah, it's okay. Go and keep on aspirin. Keep on aspirin.
You know, pull back a little bit.
Okay, good.
You want me to inject a little bit?
Yeah,
No?
a little bit. Yeah.
Let's see how the aspiration goes.
But
Yeah, looking all right. Looking all right. Keep on aspirating. The effusion is reducing in size.
Why?
Can we see the echo, please? I need to see the echo on the right side. Yeah, very good.
Yeah,
Let's look at that.
Annular of
Okay, great. It looks like that the effusion is. I suggest we give some epi straight into the LV.
Can we do that?
Yeah, why not? If it's if we have no pressures,
okay, it's good.
we're decreasing the effusion, right?
Yeah.
Good.
the effusion is much less. But are we getting any blood pressure?
It's coming slowly.
Yep.
Yeah.
Pressure is coming.
Yeah.
It's coming.
The effusion has
Can you
decreased.
intubate, Mark?
We're
Yes.
oxygenating and ventilating. I don't
What
So
is
you're
it,
okay.
uh,
Oh, that's fine.
Pacemaker catheter.
Huh?
Pacemaker catheter tip.
Pacemaker. How do you know?
Give me the patient tape.
LV.
Okay.
available. Can you help us?
But the wire.
Yeah.
I mean, wire was such a good position.
Yeah.
So let's look at the angio a little bit and minimize the echo, still keeping the screen.
The annular level.
Give me the screen on the right side.
Yeah, I know. We saw that. Yeah. We'll try to
I think
Make go to the echo or reverse them. Make the echo big and the angio small.
Never seen like a dye stain.
Beautiful.
Good.
I like
All right,
that.
now we are trying to see that where exactly.
Pressure is good.
Okay, give a blood
Under control
transfusion. Make sure we get 2 units of blood. Now, do you want to give this blood back or no?
How much blood, how much volume have we aspirated? About
Did we
300
give
About 300 now, yeah.
protamine?
No, not yet. We're going to give it right now.
No, please give the protamine first.
Okay, can you...
All right, so we're we're reversing the anticoagulation.
Just
coming
reverse
out a
the
lot.
heparin, whatever you've given.
Pressure, which one is low?
How much heparin did you give?
No, do you have
How much
It's
heparin did you give?
reaccumulating.
Yeah,
Again, reaccumulating.
very bad.
Yeah, so give like 50.
Whole.
Or give 100 milligrams.
It's annular.
Is this pericardial or this is pleural effusion?
Do you want to do a TE? The intubated.
Can you put the
Not
T probe?
intubated yet.
T probe.
Go off. Where to go off like.
Transthoracic Echo. Transthoracic Echo.
Let's show the hemodynamic screen if we can, and then we have
Can you put the T probe for me?
we have a standstill in the echo.
I don't need any PA or surgeon. Anyone, I just need an assistant.
Okay.
Have a standstill in the echo. The effusion is
accumulating?
again.
Still there is a collection, yes. Yeah.
What?
Yeah, still I think
One
I have
second,
to
can we
check
flash
for,
his catheters? Looks like the LV pressure is.
Mark, can you put the T probe in?
They're still coming very wide open.
Yeah, we're
Yeah.
just getting a team
Yeah.
ready.
Still there.
They're still there. Yeah.
Can we do a TE quickly?
Yeah.
You haven't
I think
intubated
we
yet.
may want to do an LV gram or an aortogram.
Yeah, why don't you do an algogram and check if there's a leakage?
Oh, hi. Where's your pump?
Okay, let me see.
Okay.
I think we may use the fact that we have catheters in the various
disable
parts of
my
the
mic?
heart.
I think it's a
Yeah. We need to give a patient on the bypass pump, right? Yeah. Give a little injection. In the aorta.
offline.
Let's go to the
I
angio.
think
Why don't you
what
give
we are going to do is we are going to show everything later on, put on the website, and I think we stop the transmission
I
now,
think
right?
it's 10 o'clock exactly.
Yeah.
Let's
Yeah, we
show the operators a little bit.
Yeah.
Dr. Sharma, we're dealing with the, sometimes happens with these inoperable cases.
Yes.
You have to-
And we're going to show everything in the
Later on.
website later
Yeah.
on in the archives.
Yes.
We like to stop the transmission right now
Yes.
Keep drawing.
and conclude this first 1 hour of TAVR of an inoperable patient, transmission live from structural heart livecases.org website. You can visit this website maybe later today or tomorrow for this archive case, and you can post any comments you have at info@structuralheartlivecases.org. And we'll see you back here, same time, anywhere you are in the world, on Tuesday, December the 9th.